Good morning or good afternoon. Welcome to the Healthcare and the Americans with Disabilities Act Inclusion of People with Disabilities webinar series. My name is Ann Deschamps. I am the director of the Mid-Atlantic ADA Center and your moderator for today's webinar. I am a late middle-aged white woman with shoulder-length brown hair wearing a dark-colored top. This webinar is one in a series of webinars brought to you by the Pacific ADA Center on behalf of the ADA National Network. The ADA National Network is made up of 10 regional centers that are federally funded to provide training, technical assistance, and other information as needed on the Americans with Disabilities Act. You can reach your regional center by dialing 1-800-949-4232 or visit adata.org. Slide 2. Captioning. Real-time captioning is provided for this webinar. The caption screen can be accessed by choosing the caption icon in the meeting control toolbar. Next slide. As always in our sessions, only speakers will have audio. If you're listening to the webinar, if you do not have sound capabilities on your computer or prefer to listen by phone, dial 1-669-900-9128 or 1-646-558-8656. Use the webinar ID 854-6324-8026. with the passcode 337944. This is not a toll-free number. This webinar series is intended to share issues and promising practices in healthcare accessibility for people with disabilities. The series topics cover physical accessibility, effective communication, and reasonable modification of policy issues under the Americans with Disabilities Act of 1990. These webinars occur every other month on the fourth Thursday of the month at 2:30 Eastern Time, 1:30 Central Time, 12:30 Mountain Time, and 11:30 a.m. Pacific Time. By being here, you are on the list to receive notices for future webinars in this series. The notices go out 4 weeks before the next webinar and open that webinar to registration. We are covering a lot of information today. At the conclusion of the presentation, hopefully there will be an opportunity to ask questions. You may submit your questions using the chat area within the webinar platform. For attendees that may be watching via YouTube live stream, you may submit your questions via YouTube chat function. Feel free to submit them as they come to your mind during the presentation. Slide 4, please. Submitting questions. You may type and submit questions in the chat area text box or press Alt-H and enter text in the chat area. If you are listening by phone and not logged into the webinar, you may ask questions by emailing them to ADATech, ADATECH @adapacific.org. Slide 5, please. For technical assistance, if you experience any technical difficulties during the webinar, send a private chat message to the host by typing in the chat window. Type your comment in the text box and enter. Keyboard Alt-H to access the chat box via keyboard keys, or email ADATech, ADATECH @adapacific.org, or call 510-831-6714, and that's voice and relay. Today's ADA National Network Learning session is entitled The Basics of Healthcare and the Americans with Disabilities Act. The Americans with Disabilities Act is a civil rights law that provides equal opportunity and access. This webinar will help healthcare providers understand their responsibilities under the Americans with Disabilities Act. During the webinar, we will cover three basic areas: facility access, including physical access to building and exam rooms and accessible medical equipment; effective communication with patients with disabilities; and modification of programs, policies, and procedures. Today's speakers are Jerri Davison, who is the director of the Pacific ADA Center located in Concord, California, and a member of the Healthcare Subcommittee of the ADA National Network. Myself, and as I said, I'm the director of the Mid-Atlantic ADA Center, and we are located in Rockville, Maryland, and also a member of the Healthcare Subcommittee of the ADA National Network. Emily Shuman is the director of the Rocky Mountain ADA Center, which is located in Colorado Springs, Colorado. And she is also a member of the Healthcare Subcommittee of the ADA National Network. Do you notice a pattern here? Katie Warden is the director of the Northwest ADA Center based in Seattle, Washington, and a member of the Healthcare Subcommittee of the ADA National Network. Pam Williamson is the assistant director of the Southeast ADA Center located in Atlanta, Georgia, and the chair of the Healthcare Subcommittee of the ADA National Network. So welcome to all our presenters. Next slide, please. I'm going to begin the webinar with some interesting statistics. Slide 8, please. According to the Centers for Disease Control, up to 1 in 4 adults in the United States have some type of disability. Disability is now part of the human condition and is the one minority group that we can all join tomorrow if we're not a member already. Next slide, please. Here are some disability and health statistics. 41% of people with disabilities experience obesity, compared to 29.6% of people without disabilities. 21.9% of people with disabilities are smokers, compared to 10.9% of people without disabilities. 9.6% of people with disabilities have heart disease, compared to 3.4% of people without disabilities, and 15.9% of people with disabilities have diabetes versus 7.6% of people without disabilities. And again, this is from an infographic called Disability Impacts All of Us that is on the Centers for Disease Control website, and the citation is at the bottom there. And I will mention that these slides are available for all participants on the Pacific ADA Center website. And Gabe, maybe you can put a link to it in the chat, which might be helpful for people who have not accessed the slides yet. Next slide, please, slide 10. Thank you. Disability and healthcare access barriers. Healthcare access barriers for working age adults include 1 in 4 adults with disabilities ages 18 to 44 do not have a usual healthcare provider and have unmet healthcare need because of cost, because of money in the past year. 1 in 5 adults with disabilities 45 to 64 did not have a routine checkup in the past year. Next slide. And these statistics are general statistics. So the number of uninsured people in the United States, there are 31.6 million people of all ages that are uninsured. That's 9.7% of the population. 27.5 million working age adults between the ages of 18 and 64. That is a lot of people. Next slide, please. So what this all leads to is a complex intersecting barriers that contribute to the disparities we see today between people with disabilities and people without disabilities. We have poverty, prejudice, attitudes and stereotypes, lack of provider training and cultural literacy, physical and programmatic inaccessibility, which we are definitely going to talk about today, inadequate research, and then ADA monitoring, implementation, and enforcement. Okay, now I am going to transition us into an overview of the ADA and turn the floor over to my colleague, Jerri Davison from the Pacific ADA Center. So Jerri, take it away.
Hi, everyone. I am a middle-aged woman with shoulder-length brown hair, and I am sitting just in front of a blank white wall in my local library. I am going to talk, as Anne mentioned, just giving a broad overview about the Americans with Disabilities Act and really what it means. Next slide, please. So what is the Americans with Disabilities Act, which we call the ADA for short? And so the ADA is a civil rights law to protect the rights of persons with disabilities. And we're going to get a little bit more into that definition of persons with disabilities, but we do want to emphasize the fact that this is to protect civil rights. It's like other civil rights laws to protect the rights of racial minorities or people from different religions. And the ADA is kind of that same mentality of trying to make sure everyone has equal treatment. Next slide, please. So who does the ADA protect? So that disability is obviously the big important piece of that. I think, though, we want to get into a little bit of what that disability part means, because a lot of people do not realize that they have a disability. I was one of those people. I have a psychiatric disability, but I didn't consider myself a person with a disability until I started learning more about the Americans with Disabilities Act. So it can include people with physical disabilities, sensory, which could be a hearing disability, people who are deaf or hard of hearing, or people who are blind, mental or psychiatric disabilities, cognitive, intellectual, some learning disabilities could fall in there as well, and health conditions. So things you may take medications or regularly see a doctor for could be considered a disability under the ADA. So once you've got that disability part, then you need to look at the second part of who the ADA protects, and that is that it has to affect the way you do everyday activities. So those are things like walking or balancing or climbing, or seeing or hearing or speaking, reading, thinking, understanding, remembering, focusing, sleeping. Those are all everyday things that we do. And if it substantially limits, that's the word or phrase used in the Americans with Disabilities Act, then that can qualify you for protection under the ADA. So think about whether your health condition or your disability is affecting the way you do everyday activities. Okay, next slide, please. The ADA also protects people who have a record of having a disability in the past. So maybe you don't have it currently, but you did in the past. Or if you don't have a disability, but the person that you're working with or communicating with or providing you goods and services thinks you do, then you're still protected. If you are close to someone who has a disability, if you are their child or their parent or their spouse, and you are trying to help them get services, then you could be protected as well. And the ADA also protects people who have a history of drug use but are in recovery and are not actively using drugs. So people with substance use disorder, if they're not actively using drugs, then they are protected under the Americans with Disabilities Act. Next slide, please. Who has responsibilities under the ADA? So we talked about who has rights and who's protected, but let's talk about who is responsible for making sure that they're not discriminating against people with disabilities. And we're going to talk about this just in the healthcare sense of the Americans with Disabilities Act, because that's what this webinar is focused on. But we're going to talk about public entities. So those would be state and local governments who are functioning as a health provider. So if they're operating or own a healthcare clinic or a healthcare facility, then that would be a public entity under the ADA. Also, private healthcare providers, those would fall under Title III of the Americans with Disabilities Act. So Title II is for government, and then Title III is for private providers. Next slide, please. What does the ADA require? So this is what is required of those people that we just talked about on the last slide, that services must be delivered so that all people have an equal opportunity to achieve the full benefit of the goods, programs, services, and activities, and in the most integrated setting appropriate. So people with disabilities should have access to all of the goods and services that people without disabilities have, and they also shouldn't be separated or unnecessarily segregated from their peers without disabilities when they're receiving those services, unless there is a valid reason to do so. So in most cases, the person would be receiving the services right alongside the person without a disability, and that applies to both the public and private entities, the Title II and Title III facilities that we talked about. Next slide. What does equal access under the ADA include? So equal access, when we're talking about that equal opportunity and equal access to care and services, that means that you should have physical accessibility of buildings and facilities. If you're a person with a disability, you should have access to accessible equipment to use. You should have effective communication, and that you should have the right to have policies and practices and procedures modified for you. And we're going to dive deeper into that when each of my co-hosts talk, so I'm not going to get into those right now. I see some folks raising their hands, and you may have come in late when we were doing announcements, but we're going to save all questions to the end, but you can direct message the host, Anne, and we'll get to those questions at the end. Okay, next slide, please. Are ADA requirements waived in an emergency? And I just want to point this out because we have a lot of natural disasters. We just, went through a COVID pandemic. The ADA does not go away in an emergency. You still have the rights to equal access to healthcare services at all times if you are a person with a disability. And that's really important during an emergency. And so just wanted to make a point of saying that before I passed it on. Next slide, please. So I'm going to pass it on to Emily.
All right, thanks, Jerri. Once again, my name is Emily, and I'm a white woman in my mid-30s with long blonde hair, wearing a black shirt and presenting against a green background. So as Anne mentioned, making sure healthcare facilities are accessible is really vital because access barriers can deter people with disabilities from receiving routine preventative care and early detection and treatment of minor medical issues. During this portion, I'll briefly cover some of the most important elements of facility access, and my slides are intended to be a reference for you as you move forward and learn more about this topic. Next slide. The ADA ensures access for people with disabilities, with the Department of Justice enforcing accessibility standards. The 2010 Standards for Accessible Design, developed by the U.S. Access Board, apply to public places, commercial facilities, and government entities. These standards set minimum requirements for healthcare facilities to be accessible, and they really represent civil rights by addressing physical barriers as obstacles to equal access and opportunity. Newly constructed facilities must follow the 2010 standards, and for all buildings, including those predating the ADA, accessibility rules apply. When altering existing facilities, compliance with the 2010 standards is required to the maximum extent possible. I will only be covering a few key portions of the facility requirements today, but remember to explore all 10 chapters of the standards, and of course, consult with the ADA National Network for questions about physical access. Next slide. So let's start with parking. The 2010 standards cover both parking lots and structures, and the required accessible spaces are calculated separately for each parking facility, not based on the total number of spaces across all facilities on the site. Next slide. This 2010 standards chart shows required accessible parking spaces based on total spaces. It's not a fixed percentage, so you really do need to consult the chart for the correct number. Next slide. At hospital outpatient facilities, the standards mandate 10% of patient and visitor spaces be accessible. Outpatient facilities are located in hospitals and provide ongoing treatment without overnight stays. This typically does not include doctor's offices, independent clinics, or non-hospital facilities. Next slide. The standards also cover rehabilitation facilities and outpatient physical therapy facilities. They require 20% of patient and visitor parking spaces to be accessible for facilities that treat mobility affecting conditions. Next slide. For every sixth or fraction of six, that is anything below six, parking spaces required to be accessible, at least one must be an accessible van parking space like the one pictured here. For instance, if you need 9 accessible spaces, 2 of those must be van accessible spaces. Next slide. Accessible parking must be on the shortest route to the building entrance it serves. If it serves multiple entrances, spaces should be dispersed along the shortest route to those entrances. And in parking facilities without a specific building, spaces should be on the shortest route to a pedestrian entrance, such as a sidewalk. Next slide. As depicted in this image, car accessible spaces must be at least 8 feet wide and marked accordingly, and an adjacent access aisle of at least 5 feet wide is also required. Next slide. Van accessible spaces must be at least 11 feet wide, which is 3 feet wider than car accessible spaces to accommodate ramps and lifts. As an alternative, the extra width can be added to the access aisle, making it at least 8 feet wide, the same as the parking space. And these images show examples of those two options. Van spaces are also required to have a vertical clearance of at least 98 inches for the spaces and the routes leading to them. Next slide. The access aisle is essential for transferring to and from vehicles and must connect to an accessible route leading to an accessible entrance. 2 spaces can share one accessible aisle, and users will be able to choose whether to pull in or back into spaces depending on the side needed for the access aisle. Access aisles must span the entire length of the parking space, and to discourage parking in access aisles, they should be marked with specific methods and colors potentially regulated by your state or local rules. Access aisles cannot overlap with vehicle lanes, and for angled van spaces, the access aisle should be on the passenger side where ramps or lifts are typically used. Next slide. Parking space and access aisle surfaces must be stable, firm, and slip resistant. Access aisles should be level with the parking space, and no changes in level except for slopes up to 1 to 48 are allowed in either. Curb ramps must not encroach on the access aisle or parking space in any way, like in this example image where the curb ramp is built on top of the access aisle. Next slide. Accessible parking spaces must display the international symbol of accessibility, which is pictured on screen. For van spaces, the term van accessible must be on the signs, either on a separate sign or added to the main one. Signs should be at least 5 feet high from the floor or ground surface, ensuring visibility when spaces are occupied. Signs on paths need to give at least 80 inches of headroom clearance. Signs can be installed on posts, suspended from ceilings, or affixed to walls. Next slide. The standards also cover passenger loading zones. They mandate that an accessible one is provided for every continuous 100 linear feet of loading space or fraction thereof. And these requirements typically apply only when a passenger loading zone is provided at the entity's discretion. However, there are specific facility types that are required to provide compliant passenger loading zones. Next slide. medical care and long-term parking facilities with stays of over 24 hours, valet parking facilities, and mechanical access parking garages must all offer at least one accessible passenger loading zone. Next slide. Passenger loading zones must have a pull-up space that's 8 feet wide and 20 feet long with an adjacent access aisle. This image shows an overhead view of what that looks like. Next slide. Passenger loading zone access aisles should connect to an accessible route and not overlap with the vehicular way. They must match the length of the vehicle pull-up space, be at least 5 feet wide and marked to prevent parking in them. Next slide. Vehicle pull-up spaces and their access aisles should have stable, firm, and slip-resistant surfaces, and access aisles must be level with the vehicle pull-up spaces and not have changes in level greater than 1 to 48. A vertical clearance of at least 114 inches is needed at the vehicle pull-up space, access aisle, and along connecting vehicle routes to entrances and exits. Next slide. Now, moving on to entering the building, the ADA necessitates an accessible route. Accessible routes are essential for enabling individuals with mobility disabilities to travel safely from arrival points to accessible entrances and all throughout the facility. An accessible route must connect all critical areas in a medical facility, including check-in, waiting, exam areas, bedrooms, toilets, and the discharge area, ensuring continuous access. Next slide. There should be at least one accessible route on the site, connecting accessible parking space, passenger loading zones, public streets, sidewalks, and public transportation stops to the accessible building entrance they serve. Next slide. Accessible routes must align with or be situated within the same area as general circulation paths. If circulation paths are indoors, accessible routes should also be indoors. This image shows an example of an accessible route located on a site. Next slide. The surfaces of accessible routes must be firm, stable, and slip resistant, unlike the crumbling brick pathway you see here. Next slide. Walking surfaces should maintain a maximum running slope of 5%, while ramps should adhere to a maximum running slope of 5 to 8.3%. Cross slopes should never exceed 2%. This picture shows an example of running slope and cross slope on a sidewalk. Next slide. Walking surfaces should be devoid of gaps larger than 1/2 inch and vertical level changes exceeding 1/4 inch. Vertical changes of up to 1/2 inch should have a 1 to 2 bevel. And gaps and level changes can result from issues like cracked concrete, potholes along accessible routes, or door thresholds. These images depict the ADA standards for gaps and level changes in walking surfaces that I just mentioned. Next slide. Pathways should typically be 36 inches wide, except for when narrowing at doors and for short distances. The image on this slide illustrates those requirements. Next slide. Ramps rising more than 6 inches require handrails and edge protection, which prevents crutches or wheelchair wheels from running off the ramp sides. Additionally, ramps must include level landings at the top and bottom of each segment and where the ramp changes direction. And the image on this slide illustrates those requirements. Next slide. So accessible entrances are a vital part of the accessible route, ensuring that people with disabilities can enter the facility on a firm, stable, slip-resistant surface without steps or steep slopes and with sufficient width for wheelchair or mobility aid use. A minimum of 60% of all public entrances must be accessible. And if a facility has 2 entrances, for example, both must be accessible to meet this 60% requirement. Next slide. Revolving doors, revolving gates, and turnstiles are not allowed on accessible routes, and when using double doors, at least one side must be accessible. Door openings generally need a clear width of 32 inches, although this can vary slightly, especially when door openings are deeper than 42 inches. Nothing should protrude into the doorway below 34 inches from the ground, and protrusions between 34 and 80 inches above the ground should not extend into the doorway more than 4 inches. Thresholds at doorways should be no more than ½ an inch high, and entrances must meet the same ground or floor surface requirements and changes in level requirements as the rest of the accessible route that I just discussed a few slides back. Next slide. The 2010 standards specify maneuvering clearance requirements at doorways, which vary depending on the type of door. These images show the different door types and respective requirements. Maneuvering clearances should be maintained and not obstructed with things like trash cans. Next slide. Operable parts of doors like handles, pulls, latches, and locks should be usable with one hand and not demand tight grasping, pinching, or wrist twisting. The force needed should not exceed 5 pounds. Operable parts of doors must be situated between 34 and 48 inches above the ground. Door closers should be set to ensure doors close after a minimum of 5 seconds. Next slide. Some common barriers to accessible entrances and routes include curbs without ramps, damaged concrete surfaces, any number of steps, or even grass obstructing expected walking paths. Next slide. If barriers do exist, mitigation strategies should be employed. For instance, if steps are the issue, a temporary ramp can be installed, or if one entrance is inaccessible, but an alternate one is accessible, steps can be taken to guide or assist people with disabilities to the accessible entrance. An illustration of both of those solutions is depicted here. Next slide. The minimum number of accessible patient sleeping rooms depends on the type of medical facility. These rooms should be spread out within the facility to ensure that people with disabilities have access to various areas and services. Next slide. So just a few of the features of accessible patient sleeping rooms are on the following slides. Starting with accessible patient sleeping rooms must include enough space for a wheelchair to turn around. And this can be achieved with either a circular space having a 60-inch diameter or a T-shaped space as depicted in these images. Next slide. Accessible patient sleeping rooms should provide enough clear floor space for wheelchair maneuverability, and this space should measure at least 30 inches by 48 inches and should be available on both sides of the bed. Next slide. When a patient sleeping room includes an attached bathroom, the bathroom also has to adhere to accessibility requirements. This will include features such as grab bars, accessible sinks, and roll-in showers with appropriate seating. This illustration shows an overhead view of an accessible bathroom. Next slide. And finally, let's talk about medical diagnostic equipment. Accessibility standards for medical diagnostic equipment have been developed by the U.S. Access Board. Currently, these standards are not legally enforceable, but are considered best practices. And we do anticipate that they may become enforceable in the future. Next slide. In fact, in September of 2023, the U.S. Department of Health and Human Services proposed a rule to include a requirement for healthcare providers receiving federal funds to have to follow these accessibility standards for medical diagnostic equipment under Section 504 of the Rehabilitation Act. It's important to note that in the absence of enforceable medical diagnostic equipment standards, healthcare providers still have an obligation to provide access to goods and services under the ADA's general provisions. This can often be achieved through auxiliary services like assisting with transferring someone onto exam tables or by modifying policies and procedures. The accessibility standards for medical diagnostic equipment outline design criteria for various equipment to be accessible, including exam tables, chairs, weight scales, radiological and mammography equipment. And they cover equipment that requires transfer from mobility aids and address aspects like transfer surfaces, support rails, and armrests. These standards do not address the accessibility of existing diagnostic equipment, nor do they mandate a specific percentage of new or replaced equipment to be accessible. Scoping is to be determined in the appropriate regulatory or administrative context. Next slide. So for the sake of time, I can't go into detail about the accessibility standards for medical diagnostic equipment here, but I would encourage you to review the Department of Justice's guidance on access to medical care for individuals with mobility disabilities for more information. The cover of that document and an example page are presented on screen here. Also, just another reminder, always contact your local ADA center anytime with questions about physical access requirements. As you can see, this is one of the more complex topics and often requires some research. The ADA National Network, it really is here to help you with that. There will be time for questions at the end of this presentation if I can help answer anything or clarify any of the concepts that I talked about in my section. So with that, I will pass it to Katie on the next slide.
Thanks, Emily. So again, my name's Katie Warden. I'm the director of the Northwest ADA Center. I'm a white woman wearing a dark sweater, and I have a beige background behind me. And so in my section of our talk today, I'm going to start with the legal requirement around effective communication. And I want you to know that I think it's written in a way that's a little bit confusing. So we're going to start with the legal requirement, but then I'm going to try and use common sense and plain language to talk about what this really means for us in the healthcare setting. So next slide, please. So this is it. This is our legal requirement. A public accommodation, such as a healthcare provider, shall furnish appropriate auxiliary aids and services where necessary to ensure effective communication with individuals with disabilities. And for me, my first takeaway is, gosh, what are these appropriate auxiliary aids and services? What do they have to do with effective communication? It feels a bit overwhelming. And so on the next slide, I'm going to share my take on what this is. So the basic requirement is simply the ADA is requiring us to communicate effectively with people who have communication disabilities. That's all this is about. When we're providing information, sharing information, can our patients access it, understand it? Do they have an opportunity to share information with us as healthcare providers? Is the information clear and understandable to everyone in the communication exchange? And when we're talking about people who have communication disabilities, that often we think about vision disabilities, hearing disabilities, and disabilities that affect speech. So, I happen to have type 1 diabetes. And so when I'm having a low blood sugar reaction, I don't communicate well. But in general, diabetes doesn't primarily affect my ability or the way that I communicate. And so there's different parts of the law that would apply to how I might need a modification or some assistance around diabetes. But the effective communication provision, we're really thinking about people whose disabilities affect the way they communicate. And so this is a really simple requirement, right? Are we sharing information in a way that's effective? It's also a broad and flexible requirement. Think about all the ways that you communicate with your patients and with the public, people making appointments, working with a patient in the exam room, talking to someone's parent. It's really, really a broad requirement if we think about all of the ways that we share information. Next slide, please. So I'm including this slide, the goal of effective communication, because I think it's so important to remember why is the law asking us to do this? What is this all really about? And it's pretty clear that this is providing effective communication, making sure that the information we share and receive is meaningful. That's about anti-discrimination, right? We do this to ensure that no individual with a disability is excluded, denied services, segregated, or otherwise treated differently. So when we don't provide communication that's effective, that's a form of discrimination under this law. This isn't, an extra service or being friendly. This is really about discrimination and making sure that people have access to healthcare. All right, next slide, please. So one of the ways that we can provide effective communication, that we can make sure that the information we share and receive is meaningful, is by providing what the law calls auxiliary aids and services. Another way to talk about this is as communication aids or services, communication tools. And these are simply devices or services that enable effective communication for people with communication disabilities. So we'll talk about some examples, but I want to pause and just recognize that one of the most exciting and wonderful things about disability and this part of being human is how diverse we are as disabled people, that we communicate and move and think in diverse and unique ways. And that by providing these devices and services that facilitate communication, we're recognizing that there are so many ways to communicate and they're valuable. And even if we're communicating or moving or thinking in a way that's atypical, that still is, I don't know, part of what's so exciting and diverse about what it means to be a human. And so this provision is really recognizing that people communicate in different ways and that we can use tools to facilitate communication. Next slide, please. So these are just some examples written into the law of what we mean when we're talking about communication aids and services. And I'm sure many of you are already familiar with these, and this is not an exhaustive list. These are just some examples. So working with American Sign Language interpreters, using video remote interpreting, working with note takers, having large print materials, making sure there's captioning, providing accessible electronic and information technology. These are all ways that we can help facilitate communication, right? These are ways to make communication effective. And so in the next couple of slides, we're going to start looking at some examples or scenarios to help put this into practice. What does this look like in real life? So next slide. Okay, so I've taken two examples from the ADA.gov website, their topic page on telehealth. And I've done that intentionally because I want you to know about this resource. It's a great resource. There's so many examples that are practical and really clear that can help you work through how to make this happen in your own practice. So I'm going to read this first example and then we'll discuss a bit. So a physical therapy practice uses a telehealth platform to send patients messages and videos showing how to do physical therapy exercises. One of the physical therapists is sending messages and videos to a client who is blind or has a visual disability. Right? And so this is a great example because, again, we're thinking about all of the ways we communicate. Right? It's not just scheduling the appointment. It's not just being in the exam room. What happens afterwards? How do we communicate with patients in follow-up care? So next slide. So again, the ADA.gov website, it gives us some examples of how we might provide effective communication in this scenario. So to effectively communicate with this patient, the practice may need to make sure, for example, that its telehealth platform is compatible with screen readers, that its videos have audio descriptions or audio tracks that describe and give context for what is happening on the screen. And so I think this is a great example because it brings us back to, why are we sharing this information? Why are we communicating, right? It's because as a healthcare provider, you want your patient to do these exercises, to access this information about how to improve their physical well-being. And so if they can't access that content because it's not accessible to someone who uses a screen reader, or there aren't audio descriptions, then what's the point? What is the, we want to communicate meaningful information, not just check off a box. Next slide, please. Okay, so in this next example, we're going to start thinking about, how do we decide which communication aid or service do we use? And so we're going to think about interpretation. There's a lot of settlement agreements, a lot of guidance on this topic. And so we'll use this example to get into that question. So a nurse practitioner's office uses telehealth to hold virtual appointments with patients by video. A patient who is deaf or has hearing loss schedules a virtual appointment with that office. Next slide. And so here we have some examples of what might be effective communication, but based on the information we have right now, we don't really know what will be effective. So to ensure effective communication during the appointment, the provider might need to, for example, give the patient the chance to request a communication aid or service when scheduling an appointment. They might need to provide a qualified sign language interpreter during the appointment, or they might need to ensure that the telehealth platform can support effective real-time captioning, right? And we don't know if captioning or sign language interpretation would be most appropriate, if it would be effective, if we don't know how this patient typically communicates. So next slide. So when we're deciding what kind of communication aid or service to provide, we've got some factors to consider. So we need to think about the type of communication. Consider the nature, the length, the complexity, the context, and we'll get into that more. We also need to think about how the person typically communicates. What's their normal method of communication? So for someone who doesn't communicate with sign language, that's not going to be effective, right? We need to think about what will matter to that individual. And so where we see a lot of kind of confusion and misunderstandings is around kind of what communication aid to use for an appointment with, a medical provider. Do we need to have an interpreter? Could you use notes? Could you communicate over email? How do we make that decision? And so there's a lot of guidance out there on this, especially in the healthcare setting, because there's so much confusion around it. And in general, if we think about very simple communication, so if someone's coming to the hospital to visit someone and they need to know what's the patient's room number, that might be appropriate to communicate over notes, right? Or if someone's visiting the hospital and they want to buy something in the gift shop, a really simple, brief interaction, we might be able to communicate effectively just using notes. But when we get into more complex exchanges where we're sharing information on which we might make medical decisions, then we really need to think about interpretation as a necessary communication aid, if that's how the person typically communicates. So next slide. So here, complex communication. There's a link on the bottom to a business brief that it outlines many, many examples of when interpretation would be required, is likely required. And so I'm just going to read a few of the examples here. So an interpreter may be required when you're talking about medical history or diagnoses, if you're talking about medical procedures or treatment decisions, and if you're talking about instructions for care at home, right? More complicated exchanges. Next slide. So I've got a few more things to consider when we're providing these communication aids and tools in order for our communication to be effective, right? So the tools need to be provided in accessible formats, in a timely manner, and in such a way as to protect the privacy and independence of the person with the disability. So for example, if you're asking someone who's blind or has low vision to answer questions for an intake, intake paperwork in the office, are you doing that in the waiting room where everyone can hear their answers? Is their medical information protected then? Is their privacy respected? Or if, for example, you have an electronic kiosk that maybe starts the check-in process, can someone who's blind independently access the kiosk? There are things to think about when we're providing communication aids and tools. Next slide, please. Okay, and this is a big issue here. You cannot charge for these tools, right? This is part of the cost of doing business. You cannot charge individuals with disabilities for providing effective communication. Next slide. One other issue is about companions. And so the requirement to make sure our communication is effective, it doesn't just apply to patients. It can apply to companions as well. So you might think about parents, spouses, family members, support people, people who really need to, again, have this information. Who needs to have the information? Why? And do you need to provide an aid or a service in order for them to effectively get that information? And it might not just be for the patient, right? It could be a family member or friend as well. Next slide. Okay, so on this slide, my last slide, I have an image of a model communication assessment form, and there are 2 links also. And so if you go to, it's called the Barrier-Free Healthcare Initiative. They have examples of these sorts of forms that you can use in your own practice, different policies that you can use in your practice. There are examples of settlement agreements that can give you information about how to make this work for you. How does this work in a smaller healthcare provider setting? How does it work in a hospital? And so there's lots of examples on that website that I think would be really helpful in making this a reality in your practice. And then I've also included a link to a Dear Colleague letter that I kind of outlines this requirement much more effectively than I'm sure I just did. And I highly recommend reading it, checking it out. It's got some great examples, some great explanations. And so I'm going to turn it over to Pam now. Thank you.
Thank you so much. So I'm really excited to be with you today. My name is Pam Williamson, and I am a middle-aged white woman with short curly brown hair, wearing glasses and a blue blouse. I'm going to talk to you today about access to healthcare as it relates to reasonable modifications of policies, practices, and procedures. But as you've heard my colleagues talk about facility access and effective communication, there still may be times in order for our patients and others to get equal services, then we need to be able to have these reasonable modifications in place. Next slide, please. So let's talk about what a reasonable modification is. This is a term that's used in both Title II and Title III of the ADA And basically, it means it's an adjustment of policies, practices, or procedures, if needed, to provide goods, services, facilities, privileges, advantages, or accommodations. So this means that it's going to may be some type of modification. It might be an adjustment. It might be something that's minor in the scheme of things. And then there may be some others that may be a little more major. So we'll talk about those. Next slide, please. So today we're going to talk more about some of the bigger ones. And this is the service animals and medical facilities, our reasonable modifications to visitor restrictions and medical settings, bringing personal equipment and supplies to a medical facility, and masks. Next slide, please. Well, first of all, the Centers for Disease Control and Prevention has done an excellent job of outlining when service animals must be allowed in a medical facility. And basically, here's the bottom line, is that service animals must be allowed in the facility unless they're a direct threat to other persons or causes a fundamental alteration in the nature of services. So a service animal can accompany an individual to most any place that the public is allowed to go. So that means into the inpatient services, to visit hospital rooms, to be able to go into your regular primary care doctor's office, things of that nature are allowed. The one place where it might be considered a fundamental alteration or direct threat would be if a service animal, if a person requests that their service animal go into a burn unit or an operating room where the things must be extra sterile. And so that may be considered a direct threat or a fundamental alteration in services. Next slide. Now, when you do have to make a decision about a service animal's access to a particular area of a healthcare facility, there are three things to keep in mind. First of all, you want to evaluate the situation on a case-by-case basis. So the individual and the service animal and their current health care situation are going to be the things that help move things forward, and for you to know whether or not it's going to be appropriate for the service animal to be in the medical facility. You also need to determine whether a significant risk of harm exists. And as we were discussing earlier, this might be when you're talking about going into a burn unit or into an operating room or some other sterile environment where it might be a compromise to that sterile environment. And then also look at whether or not there are some reasonable modifications and policies and procedures that will mitigate the risk. You know, is there something that can be done so that the person's service animal can be with them and during their medical appointment or other things? You know, what are some of those particular modifications and policies? And that again is going to go back to a case-by-case basis evaluation. Next slide, please. Now, if a person must be separated from their service animal when they're in a healthcare facility, there've got to be some things put into place. First of all, you want to make sure that the person, you work with the person to make arrangements for their service animal. So they want to make sure that the service animal can be cared for. And then the other thing is you need to make appropriate arrangements for the patient's need in the absence of the service animal. If the service animal has been trained to do certain tasks and that individual is going to need assistance with those tasks, then you need to be able to figure out how that's going to happen without the service animal.
So if he and his parents can accomplish that, and you don't have to spend money on the front of the house, that's
All right, next slide, please. One more. Thank you. So now,
excuse me, this is the interpreter. I didn't hear the question. Could you repeat the question? Thank you.
I don't think there was a question. I think we were just getting some feedback.
Thank you. Thank you.
Thank you. Now, during COVID, one of the things that came up was that in hospitals and medical settings, that we saw them making very strict policies about visitors, either 0 visitors allowed or only 1 visitor allowed at a time. And because of this, one of the things that happened was that there were people with disabilities who needed assistance in making critical healthcare decisions, and yet they weren't able to get the support they needed in order to be able to make these decisions. So the Office for Civil Rights and the Health and Human Services Division came out with a settlement agreement in several places that basically said, if a person with a disability needs a caregiver, a personal assistant, or a family member to accompany them, either to a medical appointment or to be in the hospital with them, then there needs to be a reasonable modification made to these visitors' restrictions. So I bring this up because although those restrictions have been lifted somewhat, they may happen again, and I just want folks to be aware that the U.S. Department of Health and Human Services is very serious about making these modifications so that people with disabilities can get the assistance they need in a medical setting. Next slide. The other thing that we saw during COVID was obviously our requirement to wear face masks. And this may come up again, given that we've got the flu season headed for us. COVID-19 numbers are going up again. And so in this particular situation, a healthcare provider is requiring all patients to wear masks due to COVID-19 or in any other respiratory type condition. And that a person with a disability is unable to wear the mask due to the disability. So must the healthcare provider make a reasonable modification? And the answer to this is yes. Next slide, please. Because you want to be able to serve the person, you need to look at what the services are. What do you need to do in order to be able to provide their service, even though a person might not be able to wear a traditional face mask? Are there face mask alternatives that a person can use? Are there ways that you can serve the person so that they don't have to be exposed to people in the waiting room versus letting them come in a different way? There may be options available and things that need to be addressed and looked at. Next slide, please. Another reasonable modification is when an individual with a disability may need to bring or use personal equipment and supplies while in the hospital. Some of those things might be assistive technology devices, a ventilator, a wheelchair, a walker, or a CPAP machine. So we are all more comfortable with our own particular devices. And many times they're set up with very strict guidance on what we need to do with them. So we need to make sure that we can allow individuals with disabilities to bring their personal equipment and supplies to the medical facility with the understanding that proper steps can be taken to clean the equipment and prevent the spread of infectious diseases. Next slide, please. So the bottom line here is that we want to make sure that you establish a policy for requesting and receiving reasonable modifications. So without a policy in place, it's very difficult to know where to go and who to ask. So that's the first thing. The second is to ensure that all staff are trained to work with people with disabilities and understand what that process is. Many times I find the breakdown to be not at the frontline level, but when folks are asking upper management about putting a reasonable modification in place, people don't always understand what's happening at the day-to-day. So make sure that all staff are trained. And again, remember to evaluate each situation on a case-by-case basis. And at this time, I'm going to turn it back over to Ann Deschamps, our moderator for today. And Ann, take it away.
Okay, thank you so much, Pam. Wow. Okay, we got through all of that in an amazing amount of time, which is great. We have time to talk a little bit about resources and how to contact us. We also have time for questions, which is fabulous because we've got quite a few questions that seem to be equally divided among physical access, effective communication, and reasonable modification. And I'm sure a few more will come in while I am talking. Okay, next slide, please. So I am going to quickly go through the resources section of the PowerPoint because we really have put together a comprehensive list of resources specifically related to healthcare and the ADA, which is for you to consult so that you can take advantage of the resources that apply to you. I don't want to spend a lot of time talking about each one because not all of them are going to apply to everybody in our audience today. So resources, ADA and healthcare basics, we have accessible healthcare from our network, the ADA National Network, and Healthcare and the Americans with Disabilities Act. Next slide, please. For ADA and facility access, and Emily gave you one of the resources in her slides, but we also obviously have the 2010 ADA standards for accessible design, access to medical care for individuals with mobility disabilities both from the Department of Justice. Next slide, please. For ADA and effective communication, we have accessibility at drive-through medical sites, which of course came out during the pandemic, and communicating with medical personnel during the coronavirus from the National Association of the Deaf. Next slide, please. Continuing with effective communication resources, COVID-19 deaf and hard of hearing communication access recommendations for the hospital from the National Association of the Deaf. Telehealth accessibility for deaf and hard of hearing. Guidelines for healthcare providers and consumers, a great resource, also from the National Association of the Deaf. Next slide. Continuing on effective communication, the American Council of the Blind COVID-19 response from the American Council of the Blind, and the National Council on Independent Living's COVID-19 information, resources, and opportunities provided by the National Council on Independent Living. Next slide. When it comes to modification in policies, practices, and procedures, we have provided a link to the ADA Title II state and local government regulations, which provide a lot of examples, and a link to the Title III regulations, which apply to public accommodations, private businesses, and hospitals. Next slide. Continuing in modification of policies, practices, and procedures, we have Title II state and local regulations and Title III public accommodation regulations, both from the Department of Justice. Next slide, please. Service animals in healthcare facilities, quite a few resources that address issues related to service animals, understanding how to accommodate service animals in healthcare facilities, guidelines for environmental infection control in healthcare facilities from the Center for Disease Control and Prevention. Next slide. Fact sheet on service animals from our network, from the ADA National Network. Service animals and emotional support animals booklet from the ADA National Network. Next slide. ADA requirements of service animals from the Department of Justice. And frequently asked questions about service animals and the ADA from the Department of Justice. Next slide. Continuing in the service animal realm, guidelines for environmental infection control in healthcare facilities and understanding how to accommodate service animals in healthcare facilities. Next slide. Another resource for concerning hospital visitors, an evaluation framework for hospital visitor policies from the Center of Public Representation. Excellent. Next slide, please. Resources for masks, the ADA and face mask policies from the Southeast ADA Center. Face coverings in business, balancing the ADA with public health during COVID-19 from the Northwest ADA Center. Next slide, please. Some general resources, COVID-19 and the ADA from the US Department of Justice, and then a health advisory, COVID-19 updated guidance for hospital operators regarding visitations. Next slide, please. Resources from the ADA National Network, COVID-19 information, disability and COVID-19, and emergency preparedness resources, including COVID-19 resources. Next slide, please. From the Centers for Disease Control and Prevention, becoming a disability ally in your community and promote inclusion for all for the Centers for Disease Control. Okay, next slide, please. So if you don't walk away with anything else, we want to make sure you know how to contact your regional ADA center. You can see a map on the screen there with the country divided into 10 regional centers. And you can identify the center that serves your state. You dial 1-800-949-4232. That's a toll-free line. All calls are confidential. Your call will be directed to the regional ADA center that serves your state based on the area code of the number dialed. You can also go to adata.org to find the local number of your ADA center if you have an out of region area code for your regional center. And again, you can also submit a form, an online form that will get directed to the center that serves the state that you are emailing from. And that's at adata.org/email. All right, now we are going to get to some of your questions. And oh, next slide, please. We've got one more. I don't want to miss this one. We would love it if you would connect and follow with the ADA National Network on Facebook at ADA Network, on X, which is formerly Twitter, at ADA National, and LinkedIn at ADA-National-Network, and on YouTube at ADA National Network. Excellent. Okay, we are going to start with some questions, and I'm going to direct the questions to the person who addressed that specific part of the presentation. So the first question is for Katie Warden on effective communication. Hi, Katie.
Hi, Anne.
So Katie, there is some confusion here because you talked about effective communication provisions that apply to people with sensory disabilities, people with disabilities affecting their hearing and their sight and their speech. Now, does that mean that people with other disabilities that may affect communication, like people with autism, people with cognitive disabilities, with traumatic brain injury, does that mean providers don't have to communicate effectively with them?
Great question. So no. So remember that the effective communication provision, this is just one part of the ADA, right? And we're thinking about different ways to create access. How do people access healthcare? How do they access information? And so the effective communication provisions are specific to people whose disabilities substantially limit, if we're thinking about our disability definition, communication. But people with other disabilities who might need, modifications to the way that we typically share information, they might need changes to how we typically experience healthcare. They could also, need a modification, a reasonable modification in order to access information. It just would fall under a different part of the law. But so I'd want to encourage people, don't worry so much about the technical part of where this falls within this big civil rights law, but the overarching requirement to make sure people can access healthcare, access information they need to have healthcare, and access communications related to healthcare.
Well, that makes sense. That makes sense. Thank you. And it means breaking down the barriers that exist, regardless of which specific part of the law it may fall under or not. Excellent. Thank you, Katie.
Thanks, Anne.
Emily, you're up next. What are the accessibility standards for EMS vehicles like rescue squads or ambulances?
This is a great question. So the ADA standards don't specifically address emergency vehicles. The ADA standards are typically applicable only to fixed or permanent facilities or sites. However, this could be addressed under the more general program access provision, which means that providers have to provide access to people with disabilities, but it's kind of up to them to decide, what that means and how to do it. So, for example, let's say someone who uses a power wheelchair has a medical emergency. The ambulance in that case can transport that person to the hospital, just like they would anybody else, and then make arrangements for the power chair to be transported to the hospital for that person, using whatever resources and means are available in that specific case.
Great. So it seems, and from the other questions too, that it really comes down to specifically case by case. And the ADA is making some generalizations, but each situation is a case by case basis. So just because they don't specifically address EMS vehicles doesn't mean EMS vehicles are not covered.
Exactly.
Okay. It really depends on how you look at access to healthcare in general. And EMS vehicles are absolutely access to healthcare vehicles.
Yes.
Great. Thank you so much, Emily. Okay, so the next one is, I think, Pam, this one would fall under you, although it probably could also fall under Emily too. If a medical practice has multiple locations, should each one have an accessible weight scale, or can a practice schedule people to be seen at the location that has one?
Yeah, this is another great question. And at this point, so we don't have scoping requirements for that. So, but best practice is showing, and if you look at the accessible medical equipment piece that we referenced earlier, so best practice is to have an accessible weight machine at each location, because if you think about it in this way, there may be 10 locations, but that means that the person with the disability may have to go to one that it may be 40 miles from their home versus the one around the corner. And so that is not equal access at that point. So you need to think about it in that way. And I would continue to follow the information on accessible medical equipment and see where those are going to play out, because I'm hoping that we're going to see information like that will help us to be able to do it. But again, it's about equal access. So look at best practice and when you're doing that.
Yes, so that's another great, thank you, Pam. And I'll go back to Emily for this one. So Emily, so following along the lines of that last question, what does that mean in terms of the medical diagnostic equipment? Do these doctors' offices have to have accessible medical diagnostic equipment or not? Because I mean, that's part of breaking down the barriers for people with disabilities.
Yeah, so, as Pam mentioned, those standards for medical diagnostic equipments are currently just a best practice. So we always encourage people to follow best practices for accessibility. You can always go above and beyond what the ADA itself requires. But even if there's not an enforceable standard for medical diagnostic equipment, the requirement again is that providers have to provide some means of equal access for people with disabilities. And so sometimes that might require removing a barrier to, their exam table, or if that's not something they can do, they might need to provide some assistance or some other method of making sure that a person with a disability has access to the services they provide.
Okay, so again, that just because they might not have medical diagnostic equipment that's accessible to people maybe with physical disabilities, it doesn't mean that they can just not offer their services to them.
Absolutely, yes.
Okay, great. So I'm seeing themes here. Okay, Katie, I have another question for you. There you are. If a patient who has requested a sign language interpreter for appointment has failed to show up for the appointment, can the doctor's office charge the patient for the cost of the interpreter or dismiss the patient from the practice?
So again, I'd be thinking about kind of equal treatment, equal access. And so you cannot charge individuals for this service. Do you exclude all of your patients if they haven't shown up to an appointment?
Right.
Right, then maybe that's your policy. If someone doesn't show up, then no one, that applies to people who have requested communication aids and people who haven't. But you wouldn't want to single someone out and charge them extra for, or apply a policy to people who use communication aids that you're not applying to other patients.
Great, thank you. And Jerri, I actually have a question for you. It's kind of a general ADA overview question, which one of the person writing the question was told that if a facility has less than 15 employees, they don't have to follow ADA regulations. Is that true? It seems like there might be a little confusion there.
Yes, so I think they're getting their titles of the ADA mixed up. And so when we're talking about healthcare and providing healthcare to the public, we're talking about titles 2 and 3. And the 15 or less restriction is for employers and their employees, and that's in Title 1. So that does not apply to providing services to the public. So that does not excuse someone who provides services to the public from complying with the ADA, which is why you didn't see it mentioned today.
Great. Thank you, Jerri. All right, Pam. I have another question about masks. So
Yes.
what if, and it's sort of effective communication too, but what about for masks, what about for a patient with hearing loss? And I know this came up during the pandemic, and the medical provider is wearing a mask. Can they be asked to wear a clear mask?
So, I always encourage folks to ask, because we're going back to effective communication. So, that was one of the things that did come up in the pandemic. And so the person who is deaf could ask that the provider wear a clear mask, or maybe there's another way that they can communicate. So, you need to be able to have these conversations hopefully prior to the appointment. And I always encourage people to be proactive. And so, yes, if that could be a way to promote effective communication, then that's definitely one of the things that could be considered, along with other options that a person might need in order to be able to effectively communicate with their provider.
Well, Pam, that brings up another question that we had here. You know, if I'm a person with a disability who may need a modification in order to get access to a provider, do I have to tell the provider in advance, or can I just call and make an appointment ahead of time, or what is my obligation?
I'm going to answer this the way my husband answers me sometimes. He's not a mind reader. And I don't expect the medical offices and medical providers to be mind readers. We've got to be able to share what we need in order to be able to access the services. That's where it comes into. And that's why it's always good to plan ahead, to start these conversations when you make the appointment, and to work these details out before you get there, so it's going to be a successful visit. Now, there are times when you may have emergencies and may need to go to the emergency department. And again, though, once you get there, if you're a person who is deaf or a person who is blind, or any other disability, and you have particular needs, let them know up front so that you can go ahead and start the process of getting an interpreter, of getting a reader, of being able to let them know that you will need help with transfers, anything like that. So those are the kinds of things that, again, we need to make sure that we can plan and try to be as proactive as possible.
Great. Yes, I think that makes sense. Your husband gives good advice. They're not a mind reading. So you want to have the best possible experience you can. So you have to educate people on what you might need. In addition, I would also add, as we have discovered, there are a lot of healthcare providers out there, and I hope a lot of them are on this call right now, who are not familiar with the specific requirements of the ADA, and they are learning. And so they are learning along with everybody else about what the specific requirements are. Now it's 33 years later, and we do have 33 years of case law. So we know how these provisions of reasonable modification, effective communication, physical access are being implemented. And that is what our centers are here for the ADA National Network. So as we begin to wind this webinar down, I will ask all of you again to please, because I know there are a huge number of questions that I did not have a chance to ask our panel members here. But I really would encourage each one of you to connect with your center, the center that serves the state that you're calling from. The ADA National Network is here to answer your questions about the ADA, to provide information. The Healthcare Committee works with the Pacific ADA Center to provide this healthcare series of webinars on the fourth Thursday every other month. And you will get information because you signed up for this one. So we really encourage you to connect with your center, and because we all provide training and technical assistance and information on the Americans with Disabilities Act, but we also have different projects going on in our specific region. So it's a good idea to connect anyway and see what your center has going on. So I think we are coming up to the 4 o'clock hour, or excuse me, East Coast 4 o'clock hour. I'm sorry. and we're coming up to the hour. I shouldn't say 4 o'clock. And I want to thank everybody. This has been a big webinar, what I think was a terrific webinar with lots of good information. And again, if you had difficulty downloading the PowerPoint presentation, please check back with the Pacific ADA Center. Apparently so many of us wanted to download the presentation that we kind of overwhelmed the internet. So please check back. And thank you, Gabe. And Gabe put the link to the PowerPoint in the chat feature. Thank all of you for attending today. Again, we hope you join us for future webinars and connect with your individual center. And let me make sure I'm covering everything I need to cover. You will receive an email with a link to an online session evaluation. Please, please, please complete the evaluation for today's program, as we value our input, and future programs will be based on your input. Thank you to my illustrious panel members, Katie and Jerry and Pam and Emily. I thought you guys did a fabulous job. And thank you all the participants for attending today's session. I hope you have a fabulous rest of your day.